In your CPT book, in your maternity section, one of the questions is going to be where they're asking if, like, it's going to say, for example, you need to know the CPT code for twin deliveries, right? So let's say you have a delivery where one of the twins was born vaginally, the other one was born cesarean. You need to know those codes. Yeah, that's a trick question they have on the exam as well. Also remember, for pregnancy coding for ICD-10, your O codes trump any guidelines for any section. Great example is like for ICD-10, for your O codes, they have a set of guidelines on how it should be reported if you have a patient that has diabetes. But then diabetes for your E codes has their own set of guidelines for how guidelines are reported. You're going to follow the guidelines for chapter 15. So if there's contradicting guidelines between chapter 15 and any other chapter in your ICD-10, your O codes trump any guidelines in any section. With your O code guidelines, the O codes are going to be used if the patient has any type of condition, because any type of condition complicates the pregnancy, right? That's your O codes. But if your patient has nothing wrong with them, it's just a standard routine pregnancy, then your code is going to be a Z code instead of an O code. Also, make a note in there as well that the O codes is only for the mother. The O codes can never be on the patient, on the baby's records. If there's something wrong with the baby will have a P code. O codes is only for the mother. P is for the baby. Make a note as well in ICD-10 that for your signs and symptoms, chapter 18, those are your R codes. Those codes are only to be reported if you don't know or don't have a diagnosis for that patient. For chapter 2, for neoplasms, which is your C codes and your D codes, the way to sequence those or to review the guidelines is you are checking to see what's the reason the patient is being seen. Because remember, the patient can have multiple different types of cancer. So you're looking to see what's the reason for being seen. Whatever the reason is for being seen, then that's usually your primary code. Now, the history cancer code can only be used when the patient is no longer receiving any treatment for that cancer. They've completed all of their treatment. That is the only time you can use a history code. So history of pancreatic cancer means that pancreatic cancer, the patient has completed all of the treatment for it. That's the only time it can be considered history. So for like history for your cancer, like when I say sequencing the reason that they're being seen, let's say if the patient got cancer that spread to their liver, right? And then they also have a different type of cancer. If they're coming in today and the treatment that the provider is addressing is for the metastatic cancer, where it metastasized to, then their secondary cancer would be primary, and then your primary cancer would be coded secondary. So you're looking to see what's the reason they're being seen. If they're coming in and they're being seen for like a complication from surgery or from the cancer, then your complication is going to be coded first. So you're always looking to see what is the reason that the patient is being seen for cancer. For your infection section, chapter 1, that talks about your coding for infections. Chapter 1 for like HIV, remember that there's two, when it comes to that, it's just broken down just into two categories. Either the patient wasn't having any symptoms or they are having symptoms. If they're not having any symptoms, they can be coded as asymptomatic. That's what they'll always be coded as. But the minute they start to have any complications or any illnesses, and it is because of that condition, they are considered a B20 and they'll forever be a B20. So in your notes, beside your guidelines for HIV, make sure you write a note that says once a B20, always a B20. Then they're going to always be coded a B20. They can never go back to being asymptomatic. Consider asymptomatic, and it'll be a Z code that they're going to have. And then there's a section in your guidelines that indicates for that same section, once that patient starts having any complications from it or complications related to it, then they'll forever start being coded as a B20. And then every record going forward is a B20. So you may see a trick question that say, patient is a patient that is known to have this condition, have had complications in the past, but today they have no complications and and they're being seen for something else. What is the code, right? Remember, they're gonna ask, hey, do you code for a symptomatic since today they have no symptoms, or do you code them as B20? The fact that they've had complications for it in the past makes them a B20, and they're going to be coded as a B20. Your I codes, hypertension, you need to know that one. That's a trick question that they put on there too.
Like the combination ones and stuff?
Yep.
For heart disease? Okay.
It is assumed. So even if the provider doesn't, it is assumed in that guideline. I think that's like in the first paragraph. It's assumed that anytime the patient got hypertension and documented any type of heart condition, right? Or if they got hypertension and they have chronic kidney condition, CKD, it is assumed that you are to assume one is because of the other, and you have to code them as one, unless the medical records state that they are not related. So if I see my patient got congestive heart failure and they have hypertension, I'm to assume that either they got hypertension because of congestive heart failure or congestive heart failure because of hypertension. Either way, I have to code them as one code.
Okay.
So it's going to be I-10 always until you see that they got a hypertension. But if they have hypertension and a heart disease for number one, then you need a minimum of 2 codes. The first code you're going to do is going to be I-11, and then you need another code to identify the type of heart condition they have, which is going to be either I-50 or I-51.
Oh, wait. Okay. Hold on. So you said I-11, that's for the hypertension
and a heart condition.
And then you also need a code to describe what heart condition they have.
Yep, which is going to come from either I-50 or I-51.
Oh, okay. And I see that note under here. Use additional code to identify type of heart failure. Okay, I'm going to highlight that.
Has hypertension and CKD, you need a minimum of 2 codes. I-12 is going to be your first code. And then you need an N18 code to identify what stage CKD the patient got. Yep. If they have all 3, which is the number 3, if they have hypertension, a heart condition, and chronic kidney disease, it'll be a minimum of 3 codes. You need I-13 to identify that they got all 3. And then you need your I-50 or I-51 to identify what type of heart condition they have. And then you need N18 to identify the stage of CKD that they have. Now, the I-50, I-51, or N18, they don't have to be in a certain order, but your primary code does need to be I-13.
Okay. The I-13 is the primary.
To say, hey, they got all 3. And then I'm doing I-50 or I-51 to say this is the type of heart condition they have. And then I need my N18 to say, hey, this is the type of CKD this is the stage CKD they have.
Okay. Makes sense. Yes, I got
you. Know what a sequela is. Mm-hmm. Remember, the sequela is because of something else. So like, let's say you got a patient that is being seen in a burn clinic today and they have 3rd-degree burn. And then you send them home, they're healing just fine. And then let's say 6 months down the line, they start developing keloids in that area. Well, when they come back in, instead of you coding it as keloids, you need to code it as a sequela, the keloid sequela, because they have it only because of the burns. Had they never got burned, they wouldn't have never developed these keloids. When you take your exam too, don't touch none of your indexes. Don't touch them. Leave them alone. You don't need your index. That is to slow you down. Because remember, you press for time. So go look at just your codes. They give you the coding options. Just look at the codes. Don't touch the index. That is going to slow you down for any section.
Okay.
And then, know your exclude notes, the differences between exclude 1 and exclude 2. So another thing you can do that makes you move faster is the process of elimination. So before you even look at the question, just look at the answers. Let's say if the answer has multiple diagnoses, then you can look at the diagnoses and see which one, if any of them have an exclude note or if they're out of sequence. If you see that there's an exclude 1 note with any of those codes, they can't be billed together. You know automatically that's not an option. For your R codes, let's say remember your R codes are always your signs and symptoms. That means that something is wrong, right? Those are only going to be reported if you don't know what's wrong with the patient. So one of your practice questions may ask you, hey, patient came in today with vomiting, stomach aches, or abdominal pain, and they have fatigue. Test was ran and the patient has gastritis, right? You know that you only need one code, and that one code is for gastritis. So if you look at your scenario, look at your options, and you see that there's options that have multiple R codes instead of just gastritis, which would be like either, I think it's a K code or A code, then you know that that is not an option because you don't code those R codes. You already know what's wrong with them.
Okay.
I know you said that for your E&M, you had the leveling. The easiest way to remember your E&M is it's going to give you all of the, it's going to give you like those long scenarios, but at the end of the scenario, it's going to say medical decision making was moderate level. That's all you need to know is moderate level and which section you're going to. You need to know that for a consult, that's a trick question they put on there too. For your E&M, consultation codes are only to be provided if the doctor has not taken that patient on as their patient. They're only they can run tests to evaluate the condition, right? They'll put that in there. So they may say, the patient is coming in for cardiology consult. The doctor did such and such test to try to see what's wrong with the patient. And then he sent their records back. Remember, for consult, it needs three things. They need a referral from a doctor. There has to be a doctor that sent that patient there. It cannot be the family that wants to say, we need a second opinion. A second opinion is not considered a consult. That's another trick question they may put on there. They need a referral from the doctor. The doctor has to be able to evaluate them. There's going to be an evaluation. And then once they find out what's wrong with the patient, they are going to send their recommendations back to that doctor that sent that patient. They're not treating the patient. They're sending their recommendations back to the doctor. The minute they start providing treatment, not diagnostic services, but the minute they start providing therapeutic or treatment services to the patient, they have taken that patient on, and it is not considered a consult. Then you need to go back. It has to be those three things to make it a true consult.
Okay.
You also need to make sure for, the difference between initial visits and subsequents for inpatient stays. Initial is the very first time that specialty has saw that patient. So let's say if that patient was in the hospital for 30 days and cardiology don't come see them until day 5, if you are coding for the cardiologist and that's their first time coming to see that patient, then day 5, when you code it, their service is going to be initial.
Okay. So the first time they see whoever they're going to see, not
see that specialty. The first time they're seeing that specialty.
Okay.
Yeah, initial and subsequent is the first time they see that specialty. Because each specialty has their own, for hospital systems, typically have their own coder. So if you're coding for the doctor, coding for the internist, right? Internists, they see the patients every single day. So that, they're the ones that oversee care. But a specialist, they are usually called in to treat that patient.
And that's the initial. And then what were you saying about the subsequent is the second time they come
That's
around?
The second time they've been seen for that second time, or any time before, any second time or any time after that is going to be considered subsequent. So if they've seen them 3 times in their hospital stay, the first visit is going to be coded as initial. The other 2 visits are going to be coded as subsequent. The discharge provider, when they code their date of discharge, their discharge is solely based upon how long did it take to discharge them. There's no medical decision making for discharge. Either I think it's 30 minutes, either it took you less than 30 minutes or more than 30 minutes to discharge them.
And I've noticed that there's a difference. Like there's one that includes admission and discharge, and then there's one that just has discharge. Are you talking about the one for just the discharge?
Just the discharge, right? That's just the discharge. The one that includes admission and discharge means that they were admitted and discharged on the same date of service.
Okay.
Also, while you in E&M, you need to know critical care. Go to your critical care guidelines. And in your critical care guidelines, it's going to tell you everything that is inclusive into critical care. You need to know highlight those services. That's everything is inclusive. because there is a trick question that may say patient got this service, this service, this service, and they may try to unbundle it.
That's
Yep.
true. I got that wrong yesterday. That's why I highlighted it.
Highlight that. Make sure you know what's inclusive into critical care.
Yep. Definitely got that wrong. And I think it was a path and lab question or something.
Or that's another trick question too. So in your pathology and lab, let me go to that section in my book. In your CPT book for your path and lab codes for 8 panels. So panels is only used for like coding purposes. It basically, they just say like, hey, a lot of times these services are done together. So it's just easier for us to make one payment versus paying them individually. That's their way of trying to save money. So your panel codes, in order to code a panel code, there must be all of those codes there must be where all those services were done, right? But there's times that they won't be all done. So let's see. Make sure you make a note. Go ahead. Because there are certain codes that can never be billed together under any circumstance. 80048 and 80053 can never be billed together under any circumstance. Make a line. You could put a line to each one saying these two can't be billed together.
Okay.
And 51 and 53 can never be billed together.
Okay.
If they are missing just one procedure out of a panel, you can't code that panel at all. You got to individually code those. Oh, your radiology. So in your radiology, you'll have some codes that have like number of views. Make sure you highlight those so that you don't get tricked up on those.
Okay.
Oh, and then also for radiology, another trick question that they have in your radiology guidelines, it's going to tell you the guidelines for with contrast whenever you can bill for contrast. Where is it? I have a 2025 book, so make sure you highlight that guideline for contrast is if they document that they gave it to the patient via oral or rectal, it does not qualify as contrast. So sometimes they may say, I gave the patient with contrast and they took it via by mouth. You can't code it considered as contrast. You just have to code it without.
Okay.
And also on that same page, the last thing for that one is knowing the difference between a foreign body and an implant for radiology. If they put something in the patient's body and it is working successfully, it's considered an implant. The minute it is not doing its job, it's considered a foreign body. Whether a piece broke off or it moved or it's no longer working, it's no longer considered an implant. It is then coded as a foreign body.
Sentence about the intra-articular, that one, that's important.
Yep. Those are the only things that are considered with contrast. Because that's the top missed one for radiology is people code with contrast that was taken by mouth or via rectum. That's the top.
Okay.
The top for musculoskeletal is not remembering that every one of those CPT codes include the initial cast or splint application. Ma'am.
Okay.
So you would just code the procedure. Now let's say.
Oh, yes. Okay, I know exactly what you mean. Okay.
Yeah. Now let's say that patient goes swimming and then they mess it up and they come in, they got to get it taken off and apply it again. Then that second time you can bill for that.
Okay. Yes, I think I got one wrong like that because I coded the cast with it. Okay.
And if you do have to code the cast, if that was all that was done on that visit, then remember you have to code your Q codes, which is the supplies, because you can code for the application of it as well as your supplies. Also, remember that for that section, your if they do an injection, you can bill for your J code, whatever injection J code they did to. And check in your HCPC book. Always verify the units and the units of the drug, because some units are 1 per milligram, and then some units are per 10 milligrams. Per 1 milligram, you need to bill it 100 times. If it's per 10 milligrams, you're only going to bill it 10 times. Modifiers, you just need to know the differences between 24 and 25. 24 means it's unrelated and the patient is in a post-op period. 24 is going to be for major procedures, which is anything that has like a 10 or a 90-day global period. 25 is the same day. Same day, and that is unrelated. I'm sorry. I had it backwards. Sorry. 24 is major surgeries, 10 or 90-day global period. 25 is the same day major minor surgeries, 0-day global period. You also need to know the difference with your modifiers, the difference between 26 and TC. 26 is the professional component. TC is the technical. The easiest way to remember is 26 is if you're billing for the doctor. TC modifier is if you're billing for the facility. But if the practice owns the equipment, then you don't need to break the component down. You just bill that code.
Oh, okay. So you said 26 is for the equipment and TC is
26 is for the provider. TC is for the equipment.
I'll just switch that up. Okay.
You need to know the difference between 52 and 53 modifier for reduced and discontinued services, because it's going to have like a scenario on the reason to stop. 52 modifier means that it had to be stopped at the discretion of the provider. So the provider probably came in and said, like, hey, they opened up the patient, realized that the could be cancer is more extensive than they thought, right? So then they close the patient back up. 52. 53 is extenuating circumstances, means that they had no choice but to stop. It could be that the patient's heart rate dropped, right? So 53 is extenuating circumstances. They didn't have a choice but to stop.
Okay.
You know those difference. And then know the difference between modifier 58, which means that it's stage or related and is during a post-op period. It has to be because they originally planned it before they did the original surgery. It's a more extensive procedure than the first one, or they're doing therapy following a surgery. 78 is unplanned. So that's one to make sure you don't mix those two up. 58 is planned, 78 is unplanned. 76 and 77 is repeat procedures. The only difference is 76 is the same provider or specialty. They look at specialties is the same providers too in a hospital system. So even if different orthopedic doctors are working on those patients, they are all considered the same doctor because it's under the same specialty. So 76 is the same provider. 77 is a different provider.
And you said they look at, like, even if they work in the same hospital, they're still the same.
Yep. So that goes with the new and established guidelines, right? So they'll tell you, like, if new patient is a patient that hasn't seen that provider of any specialty or subspecialty within the last 3 years. It doesn't matter, they're considered. So if my doctor is no longer at that practice and then I see another doctor in that practice, same specialty, I'm still considered an established patient if it's within 3 years. But if it's the same specialty or subspecialty. And also remember that non-physician practitioners or NPPs, which is considered a nurse practitioner, a physician assistant, a clinical nurse specialist, anybody that has to perform services under direct supervision, those providers, they don't technically have a specialty. when they get credentialed through an insurance company, they are whatever specialty their direct supervising provider is. So let's say, because a nurse practitioner, they typically, a lot of times, they move around the hospital. Like they'll go work for like an OBGYN doctor today, and then 6 months later, they're like, well, I want to go do a different specialty. You are whatever specialty your supervising provider is. So even if this is the first time seeing that nurse practitioner, if they seen the supervising physician or that specialty, they are still considered a new patient. I mean, an established patient.
Okay.
Mm-hmm. And then you got your anesthesia modifiers and stuff too, right? Also remember, modifier 62 is 2 providers, each working as a primary surgeon. So they're each doing distinctive things on the surgery. It means that each one is doing their own thing on the patient. Modifiers 96. It's okay. Let me kiss it. Modifiers, what is it, 96 and 97? 96 is learning a service, learning something, and then 97 is learning something all over again. Go with sister. Go over here. Go on.
Okay.
Yeah, I think that's it for those that would trick you up on the exam. Yeah, that's it for those that's trick you up.
Okay.
And remember,
Thank
for
you so
51, there's a whole appendix on codes that cannot be used in modifier 51.
Do you mind if people watch the replay, like if I post it or something? I just want to get your permission before.
No, I don't care.